coalition? We're a coalition comprised of 5 members: Students for National Health Programs for Black Lives, Latino Medical Students Association, National Policy Committee, American Medical Students Association, California Health Professional Students Alliance, and we also welcome anyone who's interested in being involved. And at the end, we'll give you some information if you're interested in being involved in this coalition. The purpose of the coalition is to get together allied organizations to work towards building a movement for health justice. We believe that we are all working towards health justice in our own ways, but we feel that if we work together, we may be able to sort of advance particular causes, just like, for example, single payer. So what is justice in healthcare? The UN International Covenant on Economic, Social, and Cultural Rights in 1966 defines it as the right of everyone to the enjoyment of the highest attainable standards of physical and mental health. And we know that that's not the case in our system, and because not all people are well served by our healthcare system, and that certain groups are disadvantaged systemically in our system and also in our healthcare system. And who are these groups? So these are the categories of otherness derived from Beverly Cheatham's categories of otherness. She defines 7 categories, and we also added immigration status. So they're race, gender, religion, sexual orientation, socioeconomic status, age, ability, and immigration status. And what we believe is that people who are part of these marginalized communities are discriminated against not only in our general society, but also in our healthcare system. And while we're talking about it, we would like to bring up the definition of what intersectionality means. So this was a term coined by Kimberly Crenshaw and she states that the interconnected nature of social categorization such as race, class, and gender as they apply to a given individual or group regarded as creating overlapping and interdependent systems of discrimination and disadvantage. And essentially what this means is that we as individuals have multiple identities, and when, for example, we look at women and the discrimination that women face, we also have to take into account that not all women face the same hurdles, and that women who belong to racial minorities, women who are socioeconomically disadvantaged, etc., face additional and unique hurdles in that community. And so when we think about the discrimination that marginalized communities face in our healthcare system, we know that it's not just by being part of a specific community, but we also have to think about the sub-communities in those groups. And now I'm going to talk about healthcare access, defined specifically as healthcare access as a function of insurance type, which is determined by socioeconomic status. I'm going to talk about how race and other forms of otherness interplay with health care access, defined as like basically access to healthcare insurance. So this first chart looks at insurance coverage of non-elderly by race and ethnicity in 2011, and it looks at employer, Medicaid, and uninsured populations. And as you can see, people who identify as white are mostly covered by private insurance, and people who identify as Latino and Hispanic have high rates of uninsurance and also being covered by Medicaid, likewise with people who identify as American Indian and Black. And this table looks at the share reporting in the past 12 months of the experience the following due to cost. So this table compares women and men, and the percentage of women and men who said yes to the questions are at the bottom of the chart. And as you can see, 26% of women are in yellow, said that they delayed or went without care in the last year. And this was a study that was done, or this data was collected in 2013. So these women went without care because they're unable to afford it compared to 20% of men. And the asterisk indicates that the differences are statistically significant. So for all of these categories, women are doing worse than men in terms of accessing care, except for putting off or postponing preventative services. This table looks at the share of women reporting that in the past 12 months they experienced the following. It's set up the same as the last table, but instead the groupings are by insurance type. And naturally, people who are uninsured are going to have the least access to care, so that's not surprising. But when we look at Medicaid and private insurance, we see that even though these women are insured under Medicaid, they're still having access issues. So the first question is delayed or wet without care in the last year. 35% of women who are on Medicaid said, yes, I've delayed care, and that is statistically different when in comparison to the group that belongs to private insurance. And so not all insurance is the same, and this sort of brings up the issue of intersectionality. So we have women being less able to access care, and then we see that the insurance status matters, and we have to remember that who is on Medicaid. We know that disproportionately brown and black people are Native Americans are the ones on Medicaid, and then we see that Medicaid, women on Medicaid are more likely to delay or go without care. This table looks at uninsurance by immigration status. And as you can see, people who are immigrants have higher rates of uninsurance than those who are not. The dates are, the gray is data from 2014 and the red is data from 2013. Both of these years were before the health exchange started, like the health exchange really went into effect after this. But we can see that people who are not born in this country have higher rates of uninsurance, and that's primarily driven by those from Central America. Sexual orientation. Now, what's interesting about this table, and this table compares heterosexual to lesbians or gays and people who identify as bisexual. When we look at insurance status, we see that people who identify as lesbian and gay actually have lower rates of uninsurance. However, when we look at those who failed to obtain needed medical care in the past year due to cost, we see that those who belong to sexual minorities, so those who identify as sexual minorities, lesbians, gays, bisexual, are more likely to have failed to obtain needed medical care in the past year due to cost. So again, it's not just insurance, it's the quality of insurance, that matters. And this table just reemphasizes the same thing. So the question is, have there been times in the past 12 months when you did not have enough money to pay for health care and or medications that you or your family needed? 25% of people who identified as LGBT said yes to that question, compared to 17%. And when we break it out by gender, we see that the impact is felt worse by women. And the issue of access, in this discussion, we're talking about access as it relates to insurance and ability to pay. However, we felt we'd be remiss to not mention the issues faced by the transgender community. These two tables look at the postponement due to discrimination by providers and the refusal to provide care by gender identity expression. As you can see, people who are in the transgender community face high rates of delaying treatment due to discrimination, and in fact are even being refused care by providers. Again, on the point of intersectionality, so who are, what do the LGBT and LGBT communities look like in terms of their racial composition? So LGBT individuals are more likely to be racial ethnic minorities and more likely to have income less than $24,000. The last one, married or living without partner, came after same-sex marriage became legal. So, and this data was from 2013, so we don't know what the current numbers are. what I find really interesting about this table, and this table is the percent of non-pediatric primary care physicians accepting new current patients by insurance type, is that it looks like on first account that providers who are accepting Medicare and those who are accepting private insurance are about the same. And as you can see, so the darkest blue is accepts new patients with given insurance type. The lighter blue here is accepts given insurance type, but not currently taking new patients with that insurance type. And so when we look at providers who are accepting Medicare and those who are accepting private insurance, we see that overall it seems like, okay, the providers are accepting equal amounts of those types of insurance. However, 21% of providers are saying that they're not currently accepting new patients who are on Medicare. And so in the future, we're going to see that older adults from Medicare are going to have issues accessing care. I mean, we already know that Medicaid is a problem, but this is going to become a problem too for people on Medicare. Lastly, we're going to talk about ability. This table compares people with disabilities to those without, and the last question here is whether or not they received care as a result of like not being able to pay or due to cost. And people with disabilities, and they're in the dark blue, 27% of the people surveyed said that they did not receive the needed medical care as a result of cost, compared to 12% of the people without disabilities. And so we see that ability is a factor in whether or not people can accept care, and through like whether people will not be able to pay for care. And so the common thread is that people with marginalized and oppressed identities have worse healthcare access and worse health outcomes. And now I'm passing it to Lily to finish the presentation.
Okay, great. So what AD has walked us through so far is looking at how people of different identities and groups that hold different identities and access to healthcare in our system. And we just wanted to make note of the fact that aspects of our lives and the society that we live in that contribute to health. And our insurance status is the gate to the gatekeeper of healthcare. The person receives insurance and a huge role in access to healthcare, but access to health and healthcare based on numerous of and so I know that many of you on this call or and many people with Desire to Do focuses on different aspects of the social determinants of health, from racism to housing to gender justice. But this presentation the work that we're focused on right now is specifically looking at the access component. So one factor, and part of the reason why we're looking at this access component is because we believe that it brings together many marginalized groups and people with marginalized identities to share in the struggle in accessing decent health and healthcare. And as AD walked us through, people from marginalized groups have less access to quality healthcare and quality medical providers. So that is one common link when we're talking about the social determinants of health. So one point that we glossed over a little, but that is extremely important, is that it's not just about who has access and who doesn't. It's also about the kind of healthcare that you have access to. And we know that people have access to very different kinds of people who have different kinds of health insurance have access to very different kinds of health care. And I'm sure that this is something that many of you have witnessed and experienced on both sides of the healthcare system, that not all sites of healthcare delivery provide comparable quality of care. And this recent New York Times article illustrated this point. The article was called "The Life-Changing Magic of Choosing the Right Hospital," and it's about the extreme importance of of choosing to access healthcare in a higher quality setting. And a quote from the article says, "There's an exceedingly simple way to get better healthcare. Choose a better hospital. A recent study shows that many patients have already done so, driving up the market shares of higher quality hospitals." So we're not going to be going in that much into the economics of the market shares that high quality hospitals hold, but are more interested right now in looking at the point of that the kind of healthcare that you have access to matters significantly. And we know that that's tied to the kind of insurance you have, which, as the data we looked at before shows, is greatly tied to the identities that you hold. So Black and Hispanic folks are much more likely to have Medicaid than our white folks. And immigrants from Central America are much more likely to be uninsured, even with the ACA, which didn't really expand healthcare access significantly for that group, and thereby have access to even worse quality healthcare. So the point that we come to is that any system that ties healthcare access to ability to pay will increase disparities in health among marginalized groups. And sometimes we don't do a great job of fully conceptualizing the extent to which this problem exists in our society and really affects our health system. We believe that it is more equitable than it is in reality. Shows that the huge of what
Oh, Lily, you're breaking up. Lily and AB, I think you may need to maybe shift positions where you are in the room if you can, because we no longer hear you. And we'll let you know when we can hear you again. It's all good. We'll just wait a minute while AB and Lily come back on.
Hi, sorry about that. Can everyone hear us now? If someone could just type in whether they can hear us, that would be great. Okay, thank you. We're sorry about that. Okay, so as we were talking about, we believe that our society is actually much, what it demonstrates is that we believe that wealth is much more equally distributed in our society. In reality, that's not the case. And so this is important for two reasons. One is that our society is extremely not equitable in how resources, wealth and healthcare resources are distributed. And the other is that we don't fully realize the extent to which this problem exists and how extreme wealth inequity actually is in our society. And so in a recent paper in Health Policy about health inequities, these authors concluded that growing health inequalities are tied to growing disparities in income and power, and that in order to achieve greater equity in healthcare, we need to focus on redistributing income and power. And we know that to some extent our society has tried to compensate for this through Medicaid and Medicare, which are quasi-national health insurance programs, and through the Affordable Care Act. Yet we know that these programs are extremely inadequate, that there are huge coverage gaps that remain, even though the ACA attempted to expand eligibility for Medicaid coverage. There are people that are not eligible for Medicaid and can't hands on these changes. And we also know that a lower quality of care that persists, there's a lower quality of care that, and that these differential qualities in care persist with the ACA, because it leaves in place a private insurance system that enables people with private insurance to access a much higher quality of care. And so when we look at expansion of Medicaid under the ACA, we can see that nearly half of states did not expand Medicaid eligibility, and in some ways the ACA actually exacerbated disparities, because in the states that did not expand, the folks that would have benefited from the expansion were disproportionately Black. So almost 1 in 4 people that were left out of coverage under the ACA, which means that they were not eligible for Medicaid under expanded eligibility, but don't qualify or can't afford marketplace subsidies. 1 in 4 of those people are Black, and so in some ways this is exacerbating racial disparities in who can access healthcare. And we just wanted to put in a quote from the recent platform of the Movement for Black Lives that was released a couple of months ago, that illustrates the point of why the point that what this quote from the platform says is there's a critical lack of quality and affordable healthcare, and it is ravaging communities of color. The ACA was an inadequate attempt at providing healthcare coverage to the spectrum of Black lives included, but not limited to people who are underemployed, undocumented, transgender, young. Hi, sorry about that again. I'm not sure what's going on. So sorry, just finishing this quote. Just start with the last sentence. We're a patriarchal, capitalist, Black who twice as likely as white people to go without health insurance, even though we suffer from chronic illnesses like high blood pressure and diabetes at a disproportionate and escalating rate. And so we see through this quote that's tying together many of the issues that we've discussed, that we can't look at these issues in isolation. And so I guess just bringing it back to the issue of health insurance, we can see that the efforts up until now have left a system of tiered care based on insurance status in place. The ACA is more of the same, and so we essentially haven't really changed the status quo in which people with marginalized identities experience worse access to worse quality healthcare. And so that's why we believe in the necessity of a single payer system. Single payer is a national health insurance system. It's also known as Medicare for all, and it's a system in which a single public or quasi-public agency organizes healthcare financing, but the delivery of care remains largely in private hands. So that essentially means that single payer is a national health insurance program that finances healthcare, but that doctors and other healthcare workers can still be employed by private entities. And we believe that single payer is necessary to be part of our shared vision for a just healthcare system. It won't remove health disparities, and it's not. It won't address all of the inequities in healthcare that we know to exist, and we believe that other sources of inequity must be addressed in tandem with fighting for single payer, but we believe that the single payer system is necessary in order to achieve justice in healthcare. And so I guess that brings us to this point that was again articulated in the platform of the Movement for Black Lives that we mentioned a few minutes ago, that in which they called for real, meaningful, and equitable universal health care that guarantees proximity to nearby comprehensive health centers, culturally competent services for all our people, specific services for queer, gender nonconforming, and trans people, full bodily autonomy, full reproductive services, mental health services, paid parental leave, and comprehensive quality child and elder care. And obviously this is a huge vision, but we thought that this did a good job of articulating part of the vision that we share in for a just healthcare system, and also articulates why universal healthcare or a national health insurance program is necessary part of that vision. And so we're still working on developing what the work of this coalition will be, and the ways in which we can support the work of the groups that are members. Some ideas that we and some of the members have come up with so far about the work that we can all be engaging in is finding ways to incorporate single payer into the work that all of you are involved in other parts of your lives. And one example of this is that the LMSA, the Latino Medical Students Association Policy Committee, recently adopted a resolution in support of single payer. And so we think that creating visibility for single payer, and likewise creating visibility for the many other issues of health justice within the single payer movement, is necessary in order for all of us to work together effectively. And we also want to be here to support you in educating your peers on single payer, so that people that are going to go out and become the health professionals of tomorrow understand what a single payer system is and why it's important for us to be fighting for a single payer system if we believe in achieving justice in healthcare. We're also going to be sending out more information for the ways that you can research issues of how the hospitals that you learn and work in enable discrimination based on insurance status and segregation based on insurance status. And if that's something that you are interested in looking more into at your school or at the hospital that you work at, we encourage you to reach out to us, and we have a lot of resources to share. And so we're still working on building our next steps and building our collective vision of what kind of we want to practice medicine in. And so we'll be sending out information about some concrete action that the coalition hopes to be planning in the next few months. But in the meantime, some things that are coming up are specifically the Social Justice in Medicine rally that's part of the LMSA conference, policy summit, that's in DC coming up this weekend, if anyone happens to be in DC. And then on October 31st, Students for a National Health Program is organizing coordinated actions at schools around the country under the hashtag Treat Not Trick, in support of single payer. And so we encourage you to look at if anything's being organized at your school, and if it's not, to plan something. And Students for a National Health Program has tons of resources to share if you are interested in doing that. And then we also invite you to join us at the CNHP conference in Washington, D.C. on November 19th. And then finally, at the end, we've included some links for further reading that go into more detail about some of the issues that we've discussed in this presentation. And thank you for joining us.